Not long ago, I received an email from a woman who was agonizing over suspicious findings on her breast ultrasound. Her mammogram had shown a probable cyst, so the radiologist had ordered the ultrasound, and the results suggested a malignancy. The woman, whom I didn't know but who had been referred to me by a mutual friend, wrote that she was freaking out, feeling hopeless and already anticipating a total mastectomy. She added that if she could have her whole torso surgically removed, she would. This woman was a 50-year-old university professor of experimental psychology, yet she was completely panicked even before a biopsy had been performed. I am profoundly aware of the fear that accompanies even a suspicion of a breast cancer diagnosis. I have been a medical oncologist for many decades, and about 60% of my practice is devoted to the study and treatment of breast cancer. In 1988, at the age of 45, my wife, Martha, was diagnosed with breast cancer. She had found a small nodule that seemed benign, but nonetheless warranted removal, and I vividly remember my fear when the surgeon told us, "I'm sorry, it's a carcinoma." I felt as though I had been walking along a rocky path on a high mountain, holding Martha's hand, and we had suddenly lost our footing. 2 days later, the surgeon told us, almost casually, that the nodes he'd sent for biopsy when he removed the tumor appeared completely normal. I regained my balance. Whatever else might turn up, there was a good chance that Martha would be cured. After Martha's lumpectomy, she received radiotherapy and chemotherapy, which pushed her into menopause. Severe symptoms began and continued unabated. She didn't complain, understanding better than I what women were expected to tolerate in that era as part of the change of life. But she was most definitely suffering. For years, the women under my care had reported a variety of the same symptoms: hot flushes, loss of sexual desire, painful intercourse because of vaginal dryness, difficulty sleeping, severe bladder pain, heart palpitations, unexplained and uncharacteristic anxiety attacks, difficulty concentrating, and the thing that especially bothered Martha, fuzzy thinking, such as trouble remembering phone numbers and following the plot of a book. And so I delved more systematically into the world of menopausal symptoms and their treatment. At the time, the uncontested most effective treatment for these symptoms was estrogen. Because estrogen therapy alone is associated with an increased risk of endometrial cancer, which is cancer of the lining of the uterus, women who still have a uterus are given hormone replacement therapy, HRT, estrogen plus progesterone, which provides the benefits of estrogen without the increased risk of endometrial cancer. Today, many physicians and laypeople dislike the word replacement and prefer to use the term menopausal hormone therapy or the even vaguer term hormone therapy. We will stay with hormone replacement therapy, HRT, in this book because it refers explicitly to the combination of the two hormones. Martha asked me about prescribing estrogen for her. Many of my menopausal patients, who had been treated for breast cancer over the years, had requested the same thing. They complained of severe impairment in the quality of their lives that they hoped estrogen would alleviate. I had always advised against it because of the prevalent concern that estrogen might increase the risk of cancer recurrence. But motivated by Martha's unhappiness over her brain fog, I scoured the medical literature to see what I could find out about estrogen's benefits and risks. It was an eye-opening journey. I began a study to evaluate the risks and benefits of HRT in breast cancer survivors, including Martha. With the women's full knowledge and consent, I administered the therapy and followed them over the years. The results of that study and many others I unearthed led me to write this book.